Again, very grateful to everybody and to our two speakers. So Dr. Liz Cuevas started her career at Mass General in various clinics in Boston and served with the homeless in the Boston Healthcare for the Homeless program. Then she moved to Pittsburgh in 2011 and joined the staff at Allegheny General Hospital. She worked as Associate Program Director for the IMRP program from 2012 to 2018 as one of the founding members for the Center of Inclusion Health at AHN in 2014 and assumed the role of Director of Primary Care Transformation. So very, very appropriate for our group. For the IM residency clinics in 2018 and then the Division Chief for Academic Internal Medicine in 2019. So welcome, Liz. And her co-presenter is Dr. Nicole Saka, who's the Associate Program Director for the residency program at Allegheny and focuses on recruitment and bringing in innovative curriculum into the ambulatory program, such as the flipped classroom model. Dr. Saka also serves as the Medical Director for the West Penn Residency Clinic and leads the efforts there on primary care practice transformation. She's the Director of Primary Care, the Primary Care Tract for Internal Medicine, the Internal Medicine program for the Allegheny program, and with a specific interest in primary care as a career. So again, Anna and I are very grateful to both of them for presenting today. Their presentation, as you can see, is the impact of the pandemic on practice transformation, very timely. And with that, take it away.
Okay, great. Thank you. Thanks so much. As Deep said, my name is Liz Cuevas. I've met some of you already on these calls, and my co-presenter today is Nicole Saka. The way we've organized the talk is that I'll be speaking for the first half, and Dr. Saka will be speaking for the second half. In thinking about and preparing for this presentation, we really had the opportunity to reflect on how much has changed over the past 6 months in our practices and what COVID has really done to our clinics and what our way of life has now become. And we felt it was really important initially to first discuss this impact onto our clinics and our clinic lives so that we can really understand what our new normal is in the current state and perhaps what it should be going into a practice transformation. And so we're going to touch on all of these questions throughout this talk. But there's going to be 4 kind of themes that you're going to hear peppered throughout. And we're going to constantly talk a little bit about telehealth, about the multidisciplinary team, social determinants of health, as well as wellness. And because these themes run throughout this talk, by the end of it, we hope that we're going to have a better understanding of the use of these 4 things and their importance in practice transformation. Before we start, we thought it would be important to kind of just have you guys understand where we're coming from and what we've done here over at the Allegheny Health Network. We are based in Pittsburgh, though the Allegheny Health Network extends into the Erie region. And sometimes I have to qualify it by saying we're the other health system in the city of Pittsburgh, the other health system being UPMC or University of Pittsburgh Medical Center. We have a 13 hospital network and we're what we call a blended health delivery system, and that we have an integrated delivery and finance system with our parent company being Highmark Health and the Highmark Health Insurance Plan. We started the transformation process here at AHN in 2017, and what we did was that we organized our over 80 clinics into what we call cohorts or waves. Wave 1 started in 2017, and about every 6 to 8 months afterwards started a new wave. We organized these clinics into what we call learning collaboratives, and we had a physician champion and a staff champion attend these learning collaborative workshops every 3 weeks, and they were given health homework assignments, and a practice transformation specialist was assigned to each clinic to help those clinics implement and work on those homework assignments. We essentially followed the path of a primary care medical home that we decided we didn't really achieve or go for getting that recognition. In the state of Pennsylvania, there wasn't any enhanced reimbursement with being a PCMH model. And at the essence of what we did with primary care transformation is we really expanded out our healthcare team. And we introduced new members into our healthcare team that are in addition to, of course, the attending physician, the resident, if one exists in the clinic, the nurse, the health and the MA. And we introduced members such as healthcare coaches, pharmacists, behavioral health specialists, social workers, complex care managers, and a clinical nurse educator. Nicole works at one of our internal medicine residency clinics. I work at the other one. And within those clinics, we have all these members of the team. Our primary care clinics, for the most part, don't have all of these members, but in some way share some of the members. And that's where we started off. And so when we thought about practice transformation way back when, in 2017 and before COVID, I always distilled it down to patient-centered, multidisciplinary, team-based care. Like I said, at AHN, we followed the primary care medical home model as our guide and our pathway. And when we initially brought these waves of clinics together and we put them in a room and we said, we're going to take your clinic and transform it, they looked at us very skeptically. They didn't buy it, and they didn't really like it at first because we were telling them they had to practice differently. And it wasn't until we introduced the quadruple aim to those physicians that they started to understand our why, and they started to understand the importance of why we wanted to transform the clinic. So now we're going to get a little bit more into depth into what COVID did to essentially infect our transformation process. And we thought it would be easiest to see this and the impact it had by talking about it through the lens of the quadruple aim. When COVID came to our hospital and to our city back in the spring, our hospital acted pretty quickly. By April, as I suspect in many of your hospitals, we were no longer scheduling elective surgeries. We weren't ordering any preventive testing. And not only that, but our patient volume really plummeted, both inside the hospital and in our clinics. We pivoted completely, almost 100% to telehealth medicine. And in doing all of these things, we lost some of it. So we looked at that first principle of quadruple aim, which is better health outcomes. It's pretty obvious that we postponed or delayed a lot of the preventive care that we do as one of the bread and butter things we do in our primary care clinics. Not only that, but there were lots of treatment disruptions for chronic disease for patients who were suffering from chronic disease, such as hypertension, diabetes, cardiovascular care. And it wasn't just the way in which we delivered care that contributed to these delays and postponements of care, but there were other reasons that we found that led to why there were disease disruptions. That included a lot of social determinants of health. So the inability to access public transportation or have other transportation needs, the inability to access healthy food, the engagement now in unhealthy activities because of stay-at-home orders and lockdowns, such as the lack of physical activity, the start of smoking, or the increase in alcohol or drug consumption. It was all compounded by the fact that the finance situation in the US at that time was not doing well with the employment, and compounded by all of the stressors of such as having kids at home and trying to learn at home. There's great, you guys are probably pretty aware of the Primary Care Collaborative. They put out a survey of primary care doctors, and they do that every month they have a new survey where they ask primary care doctors what are their experiences in their primary care clinics now. And large numbers of those clinics have had shutting down of their quality initiatives, as well as the number of services that they're offered to patients. Now, unfortunately, we don't really know the full impact of these disruptions in care and these preventive measures. I suspect we'll find out soon, but right now it's unknown. Of course, I don't have to tell you that there are health disparities that were put in the spotlight because of COVID. We see certain racial populations, such as African Americans, Latino, and American Indian populations, that have experienced infection rates that are higher than what we would consider to be expected based on their number in the population. Hospitalization rates and in some cases mortality rates are higher than would be expected. And not just within racial populations, it also exists within socioeconomic populations. So those who are dually eligible for Medicare and Medicaid have higher rates of hospitalizations with the COVID. There has been a plethora of opinion pieces and viewpoints and evidence around the health disparity issue when it comes to COVID. And there's a ton of them out there that are beautifully written. One that struck me really was one by Dr. Clyde Yancey from Northwestern, who essentially said that being able to maintain social distancing is really an issue of privilege. And that struck me and made me really think about what we have to do here in our clinics. You might notice that we're going to have a few Pittsburgh slides interspersed throughout all of this because, you know, it's Pittsburgh, so we have to showcase our town. But going back to that primary care survey of physicians, you'll see, and they were asked, what are they seeing now in their clinics? And they're seeing lots of increased rates of patients suffering from inability to access some of those basic social needs, such as housing, food, ability to afford their utilities, and with that, increasing numbers of unhealthy behaviors and worsening mental health states. Now, if we go to the second part of that quadruple aim, if we're trying to achieve a lower cost of care, that impacts many different levels of care, from the patient to the healthcare system to the insurance company. As you know, employment rates are going up, and the Urban Institute predicts that 10 million people will lose their employer-sponsored healthcare insurance plan by the end of this year. Now, if you look at those 10 million people, they speculate that about a third of those people will be able to get onto their spouse's employee-sponsored healthcare plan. About a third of those people will be eligible for Medicaid or an insurance product through the healthcare exchange made available by the Affordable Care Act. And a third of those people will be left uninsured, which will impact the cost of care overall in the US. If we look at hospital and health system costs, we can see that it's estimated that in the US, $50 billion per month over the first 4 months of the pandemic was the cost of the COVID care. And I think the insurance plan is really interesting. The insurance story is very interesting because though COVID care does cost insurers quite a bit, with estimates anywhere between 30 and 550 billion, depending on the percentage of the population affected, insurance has a flip side to that. As we just discussed, there are a number of patients that we have seen who are not getting the preventive care that they need, or the chronic disease management that they normally get, or even fill the medications that they normally fill. And as a direct cost of that is that there are no claims put into the health insurer for those services, which ends up leading to some saved costs. So for example, I'll throw in our health plan. Again, we're a blended delivery system. Highmark Health is our parent company. And they released in August that for the first 6 months of 2020, they had a $511 million excess in revenue over expenses. And it was good for us because at AHN, we lost revenue because of the cost of care and because of the decrease in a lot of our procedures and surgeries. And so it helped us out a lot. But there's an interesting story in there around insurers. This was our sinkhole. We had a sinkhole in the fall of last year. I thought that was a good picture. And though I know that the lower cost of care, when we refer to the triple, in terms of the quadruple aim, is really meant to refer to the lower cost of patient care, I would be remiss if I didn't point out that there was a unintentional cost to physicians, staff, and clinics, because COVID directly led to physician and staff being out of work due to COVID or quarantining, due to having to lay off staff if they couldn't make their ends meet. And it led to decreased patient volume and a subsequent decrease in revenue. We look at the third part of the quadruple aim, the improved patient experience. In our healthcare system, we had back in the early part of 2020, a whole program for the Allegheny clinic physicians. Each physician was supposed to take a one-day retreat to learn communication skills training. They were going to take us out of work so that we could learn how to communicate with patients better. And of course, when COVID hit, that program was scrapped, postponed, probably we're not going to do it all together. But that's true of several other programs that revolved around patient experience. So patient advisory councils, consumer advisory boards, even patient experience surveys were either postponed, delayed, or not done because of the COVID experience. Now, the telehealth brought a lot to us, and we were able to access our patients in a way we never had before, which was fantastic. But it added an extra layer. It was different, right? It was a little bit distant. And in some ways it was difficult, especially if the technology didn't work. And that added to perhaps a decrease in the patient experience. The impact of social isolation on our patients and our staff, to be honest, cannot be ignored as well, where we see certain populations of patients who really relied on their social networks suffering because of the stay-at-home orders and the quarantining that had to be done. And we see that reflected in our patient encounters. Again, going back to the Primary Care Collaborative and their survey, and we see lots of pressures reflected on providers and staff within our clinics, lots of stressors that have come that we've never experienced before. And in addition to all of these stressors is really an uncertainty and almost a fear of what's going to happen. A lot of us in our clinics are facing longer work hours, sometimes taking on new jobs and responsibilities that we weren't aware that we had to take on before. In some cases, being ICU or ER docs or triage physicians, where we hadn't had to do that before. Primary care doctors across the country are facing income struggles if they're not doing enough inpatient care. And one thing that we wanted to point out was around the teaching. Many of us on this call are clinician educators, and teaching is a mission, it's a passion for us. When COVID hit, of course, and medical student rotations were stopped, and residency experiences were really consolidated to include just the essential services, we lost some of that teaching. And I think that impacted some of our own well-being and health. And that's where we were. That's what COVID did to us. It really did shut a lot of it down. One by one by one, it shut down all kinds of practice transformation efforts and changes and programs that we had put into place. But not only that, it showcased and highlighted some of the weaknesses in our system and in our practice transformation efforts. It has never been before so obvious that we need better solutions to reach patients and deliver care, that we need to do more to address healthcare disparities and social determinants of health, including creating interventions for those, that we need to recognize the importance of prevention and screening efforts on population health, and we need to support our healthcare workforce and their wellness. And so for a lot of us, we opened up our clinics maybe in the late spring, early summer, and we started to see more inpatient volume. But I would argue that it was a different kind of world in which we were seeing them. For many of us, we were playing catch up, and we were putting out fires and dealing with acute catastrophes and just trying to figure out how do we do this with all of these new changes, sometimes staff reductions, sometimes dealing with these new physical barriers like masks and shields, which I do hate wearing, but of course I do, and restrictions and minimizing contact. There's all kinds of checklists out there. You can Google about how to open up a clinic and what is your new normal. And one of the pieces that struck me, one of the checklist items is make sure that you do the absolute minimum in the patient room and run out as soon as you can. And that struck me as sad. But feeling the stress from coworkers in this new environment. And to get back to transformation, it's very important that we understand what COVID did to us so that we know how to move it forward. What we have to do to change it a little bit, because though we've been doing this opening up of clinics for 3 months, I think it's time now that we go back to the transformation principles, but do it with a little change. Do it understanding that COVID is around and we're gonna have to alter what our original plan was.
Okay, so now we're going to talk about refocusing on practice transformation.
Nicole, do you mind if I just stop for just 1 second before you take over? Just because usually I have introductions for everyone in the group, and we have more people that join the call. So before we move on, do you mind if I just have everybody, we're a small group, and just introduce everybody, and then I'll have you go. Is that okay?
Yeah, that's fine.
Great. I think Adil.
Hi. Hello.
You want to just introduce the two
Yeah.
seniors from?
My name is Hadi Alki. I'm primary care physician in Amhas Hospital, New York City Health and Hospital, clinical instructor for Mount Sinai.
Great. Kim?
Hi, this is Kim Pierce. I'm an internist at Johns Hopkins.
Bob?
I'm Robert Oy. I'm a primary care general internist at UCLA and have been involved with the practice management for many years, and know Deep from when he spent time with us.
Jennifer?
Hi, I'm Jennifer Zriloff. I'm a general internist at Emory.
Great. Nancy?
I'm Nancy Kubiak. I'm just moved to MAHEC, which is Mountain Area Health Education Center in Asheville, North Carolina, starting the new residency clinic there. And this organization is very focused on health disparities and changing health nationally and locally.
Great. Our fearless leader, Stacy?
Hey guys, I'm not sure what is going on with my video, but just wanted to say hello. I'm at Emory. I serve as medical director for the primary care center there and have really had the pleasure of being on the committee for CPC and seeing all the great work that you guys are doing.
Lisa?
Hi, my name is Lisa Rottenstein. I'm a primary care physician and I am a medical director for care management and care strategies and innovation at Brigham and Women's Hospital. So great to see everybody.
Great. Erica? Maybe Erica's not there. Anna?
Hi there, I'm Anna Rollerman. I'm a med-peds primary care physician at University of Chicago, as well as a health services researcher.
Great. Did I leave anybody out? And my name is Deep Singh. Just to remind everybody, I'm the clinical chief here at Stanford and the co-director of this committee with Anna. So any questions before we go to Nicole's part of the presentation? That was a very nice presentation, Liz. All right, take it away, Nicole.
Thank you. Nice to meet all of you. So we're going to talk about refocusing on practice transformation now. During COVID and post-COVID, we know now that what we were doing before for practice transformation will need to be adapted in ways to account for the problems that COVID brought to light. So how do we really reinvent practice transformation? And we think it really needs to include these solutions. So making sure we're providing a safe environment for our staff and for patients. Restarting our work on population health and quality initiatives. Focusing on non-communicable disease prevention and management again. Mindful attention to health disparities. Creating innovative solutions to reach our patients. Engaging our multidisciplinary team, reintroduction of patient feedback so that we can continue to improve, and also really talking about staff and provider burnout. Next slide, Liz. Thanks. Okay, so clinic safety is obviously very important. So looking at areas like having PPE and social distancing to make sure that everybody feels safe when they go to work. And this is something that we've done and we're constantly working on in our clinics. This is an example of one of the posters our institution provided us that we have all over our offices right now, and when you come in and when you leave, to make sure that everybody is wearing a mask who is patient facing and who is working with other staff. But we need to, make sure that we have access to acquire the right PPE that we need. We need to make sure that we have the correct PPE and that everybody's trained on how to wear it so that it's effective. We need to make sure that we're all champions in our offices to make sure that we are all wearing the PPE to keep everybody safe. And maybe being a little creative as far as the workspace goes so that we're following social distancing protocols. So talking about non-communicable disease prevention and management. So this is going to include, things like vaccinations, Going back to our cancer screenings that have been delayed, pre-exposure prophylaxis for HIV, depression screening, blood pressure screening and weight checks, STI screening for our young and adolescent population. All of these other things for chronic disease management that are, necessities and obvious, but that we necessarily haven't been doing in all of our patients because we can't safely bring them in or get them access to the right equipment.
Nicole, may I interject something on your previous slide, which was just about being creative with the workspace?
Sure.
I just wanted to share that at our institution, we have our resident and our scheduling team, they kind of comb through the days, and we only allow 5 residents into the pod at any time, so that they have not only 2 clinic exam rooms, but a 3rd room that serves as their work room, so that we aren't using our sign out room in the capacity it previously was used for. So I don't know, we certainly can't tear down walls and do anything major, but that's the way we've kind of addressed it. And so if more residents are available than the 5 slots, we will convert those to virtual templates.
Yeah, we've done something very similar to that as well. Now with the new first years, just in their first weeks of training, we've really tried to keep them in the office so that we can get them trained up on how to use the EHR, how to do telehealth visits before we let them work remotely. So our more senior residents, if we need to socially distance more in the office, we're having them do more remote visits. So we're doing something very similar, and that's really what we need to do to be creative and try to keep maybe some staff at home as well that can help with the telehealth and respiratory clinics so that we can separate out patients with respiratory complaints. Okay, you can go to the next slide. Okay, so vaccinations, very, very important. Right now, most of us just got our influenza vaccines that we're going to try and distribute to our patients. We need to be more creative now, right? Because not everybody's comfortable coming into the office. And if we're doing telehealth visits, they're not coming in, and we're missing an opportunity there to get them vaccinated. So looking at things like curbside and drive-through vaccination clinics, we've talked about doing this in our offices as well and using our parking lot. Getting vaccines out into the community where patients are going to be, such as schools and church programs, partnering with CBOs, home health partners, which we're lucky to have some of these programs, such as mobile integrated health, and we have a paramedic program that actually helps patients at home with diabetes that can't leave the house, but maybe expanding these efforts and offering home vaccination solutions here as well. Street medicine, shelters, and food pantries are a great opportunity to reach those patients with health disparities. This is going to be very important once we get an effective COVID vaccine, so we need to start preparing for this now. And really using the mindset that every visit is an opportunity to vaccinate and to give multiple vaccinations at once. And also for some of you not doing standing orders, revisiting letting your clinical staff use standing orders to vaccinate patients without a physician sign off. So as many of you, we are in a catch-up period right now that's months of backlog patients who are unable to get routine testing. So we need to be really proactive about this. We need to be running population health reports to figure out which patients are in most need and how we're going to reach out to them and get them tested in a reasonable time frame. We also still have patients who are worried about leaving their homes, so they're delaying testing due to safety concerns, and we have to educate those patients that there are safe ways that they can still get the preventative screenings and testing that they need. We've had this problem at our institution as well of screening tests not being prioritized right now. So even patients willing to get mammograms and colonoscopies and DEXAs, the facilities aren't able to accommodate them in a timely manner. So they're pushed out for several months. And really, is that acceptable? We probably need to be looking at more creative ways to get these patients in sooner. So if we're going to monitor chronic diseases from home and do telehealth visits, we need to make sure that our patients have access to the equipment that they need. Blood pressure cuffs, sometimes not as easy to get, especially for patients that don't have access or can't afford a blood pressure cuff and not covered by the insurance. Thermometers, pulse oximetry, heart rate monitors, scales, simple things like this that if we're going to be doing video visits and telephone visits, we need to be monitoring. Point of care testing for patients who are on warfarin. Simple solutions that could limit patients needing to come into the office. And using multimodal patient outreach. This is going to be more important than ever, and it's something that we're guilty of in our institution and not really paying attention to until the pandemic hit. But as we all know, different patients have different needs. So if we're going to reach all of our patients, we need to continue to make all of these a priority. So not going back to the traditional of just in-person visits only, because we know we're going to miss patients who could only do video visits, or if they don't have smartphone capability, we need to still be offering telephone visits. And we need to get creative with group visits because these are appropriate in some situations as well. So we need to make a safe environment for patients to continue with group visits. Having access to all of the clinical support staff. So we can't just let the clinical pharmacist, dietitian, and social worker and behavioral health consultant be available to those that come into the office anymore. We have to make sure that they're also offering video and telephone visits, which most of our clinical support staff has converted to now, and they are offering audio and video visits as well to those patients who can't leave the home. So we need to refocus, right, on quality improvement programs and population health programs that we've put off now for months. And it does seem like a daunting task, but physicians need to lead this and get their clinics and their staff involved in this again, get the residents involved in this again. Although a lot of this can be insurer dictated, we really, as the clinicians and as advocates for our patients, need to determine which quality initiatives should be prioritized right now and where we can make the most impact, since we are playing catch up right now. And then moving forward, all of this needs to be re-examined. Go to the next. So patient engagement. This is tricky now that we're not seeing patients as much in person, but we still need to focus on this. So frequent engagement with their PCP right now, we know is more important than ever. And our institution is really trying to stress this to patients, that even if you're scared to leave your home, we are probably one of the safest places that you can go, because we're focusing a lot of our efforts on this. And it's really important for you to still continue to do your annual wellness visits with us, to come in for your vaccinations. It's really important, for a pediatric population as well. So we're trying to get this message across, but we're not seeing our patients as much. So how do we do this? So more frequent touch points with our patients. Our medical assistants could be doing this via phone calls. Our health coaches who are trained in motivational interviewing could help to do this. Nurses, and our BHCs and our social workers could help in this area as well. We also need to make sure we're getting feedback from our patients still. We need to know how we're doing with telehealth and where we can continue to improve, since this is a new area for all of us. And we're just not getting this information back from our patients yet. So we need to look at this in the future. Okay, and so improving the patient experience in telehealth. This is a big topic right now, as you all know. With video and audio, still making up a sizable portion of visits right now. In-person care is complicated by the physical barrier of PPE. We are wearing a surgical mask and a face shield for every patient encounter. It's important that we incorporate the emerging best practices to create a presence here. So website manner, which is a new term, in the telehealth world. We need to have more physician training and resident and med student training on this, since this is what we'll be continuing to do in the future of medicine. Like things like greater attention to vocal tone and tempo, facial expressions and body language, right? Mindful practice, an extra effort to make sure your patients are understanding, slowing down so you don't seem rushed. Even simple things like being in a well-lit space, free of distractions and noises in the background. And giving your patients clear instructions so that they're comfortable during the visit as well. And having maybe your MA do a dry run while they're waiting for you in the virtual waiting room. In-person visits are changing a little bit too. We're now wearing these masks and face shields, which can be scary for some patients. We're used to seeing providers wearing this PPE, but they are not. It can muffle your voice, and so you have to make sure you speak really clearly. You may need to use eyebrow raises and extra hand gestures so that they can read you a little bit better, since they can't see your mouth. You may need to provide more eye contact. And also you really should talk about the unexpressed anxiety and uncertainty that your patients are having, because most of them are having this. And then be sure to discuss telehealth visits as an option for follow-up, so that they're aware and they're prepared that maybe the next visits will be telehealth visits instead of in person. Next slide. Okay. So something that we can't forget about with a quadruple aim is improving the experience for our clinical staff as well as for patients. So interestingly, right, pre-COVID, there was a study in 2016 that showed that US physicians and their staff spent more than 15 hours per physician per week dealing with external quality measures. Another study in 2009 found that US physicians and their staff spent 60 hours per physician per week on prior auths and other interactions with insurers. Yeah, that could burn out anybody. That's not the fun part of our job, right? So post-COVID, we really need to focus on these issues, trying to eliminate requirements for orders for low-risk activities like ear irrigation, finger sticks, things that our clinical staff can be doing, using standing orders, which our institution just started to allow us to do again for vaccinations, so physicians don't have to sign off. And really thinking about retaining only performance measures with evidence of favorable cost-benefit ratio. And I think most importantly, monitoring health professional burnout. And I'm careful to say health professional burnout because this includes staff as well as physicians, and using that as an indicator of how a health system is performing. So social isolation, and specifically patient isolation here, right? So we need to make sure that we create a safe space where we can see our patients. We also need to make sure that our behavioral health consultants and our social workers are involved. And for those who are at higher risk, so patients with prior mental health and also the elderly population, maybe they do need more frequent touch points from our BHCs and social workers. For the elderly population, simple things could be simply involving their family for more telephone contact, more frequent telephone visits with nurses or providers, and health coaches, reaching out who are skilled in motivational interviewing. So physician and staff isolation, we felt was important as well because we're seeing it. So we need to, work on this as well and make sure we continue to create a sense of team, because we are all a multidisciplinary team, and that's the focus of practice transformation. So we've done things like virtual huddles with our team when we're doing telehealth, so that we're still being involved with one another before patient visits, and we'll do that each half day for about 10 to 15 minutes prior to our session starts. It also involve your trainees or med students if you have students with you as well. Try to create a joint purpose. So everybody can work together towards that same purpose. And this is a great opportunity to start up your quality initiatives again. Check in with your providers and staff often about how they're doing, right? How are they doing outside of work? Are there financial stressors? Are there things that you can help with? Is there concern for mental health issues? Are they feeling burnt out? So things that we should readily be talking about and areas where we can get them help. Okay, so physician burnout, right? This is a hot topic even before COVID, but now I think we have national attention on this, as we should, but we really need to preserve physicians during and after this pandemic. So, continue to permit verbal orders like we talked about, and this is inpatient and outpatient. Eliminate documentation and signature requirements for low-risk interventions that we get bogged down with. Use of in-person or virtual scribes. This is something we've been hearing about at our institution for a long time, but we haven't actually seen put into effect yet. Require less note documentation, which will improve somewhat with the CMS changes for 2021. Allow MAs to perform medication reconciliations, which we don't currently do, but would be helpful. Simple things like limiting logins and using your badge to swipe in and out. There's interesting data on just how many minutes a day that physicians spend just signing in. And then obviously, if we could allow the E&M coding to be applied to video and telephone visits even after the pandemic. And I think this quote is true, that the relief from extensive administrative burdens that we've been allowed during the crisis is already being felt, but it's not enough and needs to continue. Okay, and so last and probably most important for a lot of us is education. So we saw the statistic that 34% of programs really cut back or completely removed educational programs during COVID. I would probably argue that it was even more than that, and a lot of us had at least cut back. So we need to bring medical students and residents back to the clinics. We've already started to do this. We've actually been doing this for months now, but we really need to prioritize medical education. But we need to make it safe for everybody. And just as we heard, same thing that's happening in other places, we can get creative and socially distance. Let some of our more senior residents do more telehealth, use different rooms than we've used before. It's really important that we involve residents and students in telehealth because they need to know this new idea of website manner, because they're going to be living this here in the next few years when they graduate. And I think important for all of us is that for clinician educators, it really gives us a sense of purpose again. This is what we have signed up to do. This is what we're passionate about, and it can really help to reduce our stress and our burnout and improve job satisfaction. And I like this quote. So just because something works doesn't mean it can't be improved. So this is, a constant work in progress, practice transformation is. And yes, we've been set back a little by the pandemic, but I think it's going to allow for a lot of opportunities to make improvements that we didn't see before. And I think this will really be a blessing in disguise. And so that concludes our talk. But we would love to do a workshop for SGIM on this in the future. If anybody else is interested in joining with us and talking about practice transformation. So I'll leave it open for questions for Liz and I.
So thank you very much, Liz and Nicole. That was a great review of kind of all of the struggles that I think many of us resonate with at our own institutions. And so there was a lot of activity in the chat. So maybe I'll open it up. I think, Stacy, you had a question that about mammograms, PAPs, and colonoscopies and how people are doing that, and that generated a lot of questions. maybe I'll ask Nicole and Liz how you guys are doing that. Maybe you'd open up to the group.
Yeah, mammograms were not being scheduled for a while, but we're back to regular scheduling of mammograms. Most people can get in within several weeks for those, probably about 4 to 6 weeks out. So that's good. Pap smears, initially, we saw a response from OB/GYN docs that they didn't know which PPE to use when they were doing pelvic exams. And they were also afraid to bring at-risk pregnant patients in for appointments as well. But I think now that they're more comfortable with the use of the PPE and they have correct guidance for which PPE to use, most patients are able to get their PAPs done without an issue. We're doing pap smears in our office as well. And what was the other one, colonoscopies?
Yeah.
Yeah, same. We had deferred colonoscopies that were non-urgent. And now we're back to doing elective colonoscopies, but there is a backlog on the colonoscopies for sure. We have some initiatives in our institution where we do Saturday colonoscopies, which has been really favorable for our patients. So I think that we'll probably be opening up more Saturdays for routine colonoscopies.
Yeah, I think, Bob, I think you were saying, and we're the same, that we're doing COVID testing 48 hours before colonoscopies, like we are for elective surgeries, and I'm sure many of you guys are doing as well.
Yeah.
Other comments and questions? Any struggles that people are having in their institution with some of the issues that Nicole and Liz brought up today? I will bring up one thing that I think you alluded to, Liz, about the stress on providers. So in my own institution, we've seen an uptick in abusive behavior actually towards physicians. And I was wondering if anybody else was noticing that in their institutions. And we've had to sort of, as a wellness issue, take that on. I don't know if it's the stress of people, but there's been an uptick in a lot of the sort of general anger and frustration that people are taking it out on our staff and our physicians. I don't know, Liz or Nicole, if you guys have seen anything like that at your institution.
We've seen a little bit of it. We have a couple. One of our clinics is located in the north side of Pittsburgh, which is not, which is a little bit of a rough side of town, and we have seen. Perhaps because of the increase in drug activity that's happening outside of our clinic walls, getting through that clinic and walking into the hospital, which is about a block away, has been a little bit difficult, and there's been some situations there. I think once the stay-at-home orders were lifted and people started coming out on the streets, that started up again. We haven't seen a lot, though, of patients being aggressive towards doctors. Though there's a lot of frustrations that are coming out with telehealth, not being able to access the technology, and not being able to get the testing that they wanted.
Yeah, I think there's some abandonment that a lot of patients are feeling, that they're expressing to us, that we weren't available for a while and they felt like we had abandoned them. So we are still seeing some of that hostility when they come in for visits, that they feel like they don't really have access to us when they need to. So just, engaging them and getting that message across that we are there for them. But yeah, we've seen it in that way, but not really aggressive behavior.
Some of the stresses that we see are just from the reduction in income at the practice level. And that in the Department of Medicine, we're a huge enterprise and have like 150 clinics, but we've been able to maintain our volume. Initially, it shifted. We had 0 televideo visits when it started, and then it went up to 40 or 45% with a number of telephone visits as well, though we tried to shift people to televideo, but old people have a real hard time, doing that, at least with the Epic system. And we pretty much have hung in there. We're about 90 95% of where we were before the pandemic started. But looking at other departments, it looks pretty bad. I mean, some are down 20% or more in revenue from previous year. And, I suspect they're having to lay people off and do things like that. The campus has also been really affected because all the research operations got shut down other than sort of keeping mice alive. And a lot of people have been really having to be very innovative in terms of maintaining their research programs because they were locked out basically. And I know that has caused stress with a lot of the campus research faculty. And then just the whole shifting to online education has been huge for many of the medical school faculty who've had to, I'm the director of clinical skills, and I had to switch to online clinical skills training, which is a bit of a challenge with about 10 days notice. And but these are all there are many organizations directed at these things. The directors of clinical skills has been very active and has a lot of smart people who've come up with nice ways of doing it. So outside of SGIM, there are other resources that are looking at these things, but my chair was very aggressive about following the number of visits every day, and we circulate this. We have a lot of clinician educators, and so it's been followed very closely. We also just looked at people who had a disproportionate number of telephone visits, because when we look at it, the telephone visits just don't result in referrals as to the same degree. And so all the specialty practices were hurting for that reason, but they've been coming back pretty well. And oncology just sailed right through. They didn't slow down one iota during the whole thing.
Cancer never slows down.
Yeah.
And thanks for sharing, Bob. Is there anybody, I think the deadline for SGIM workshops is coming up, if I recall, in the next month or so. So this is a great opportunity for someone to partner with Liz and Nicole. Is anybody interested from this group about potentially putting a workshop together? Certainly, Liz, if you need somebody, I'm sure I can dig up someone from my institution. So please reach out to me.
Yeah,
and I'm happy
sure.
to. We're always looking for partners.
That'd be great.
I would be interested in. This is Kim. I can put my email here in the chat if that helps. So if you can hold on to that.
Great, thank you. I'd love it.
Great. We have about a couple minutes left. Any other questions, comments? Things that people are dealing with? Otherwise, I want to be sensitive to everyone's time. I want to thank Liz and Nicole for a really nice presentation, give us a nice flavor of what's going on. Like I said, I think many of the themes that you highlighted resonate for all of us. And it's nice just to hear that we're all sharing in the same kinds of frustrations. I got a few good ideas. I like your website manner. I like that a lot. Definitely use that. And also the idea of trying to put in standing orders for low acuity items that our MAs can do and our RNs. So this is the kind of thing where we're trying to give ideas and share our best practices and frustrations with one another. So
Steve, I just like that comment. You may have something like this at your institution, but we have a program called RISE, which is Resilience in Stressful Events. And it's a peer support group. Albert Wu heads it with the chaplain support. It's a whole multidisciplinary group, but they do training for essentially peers, so nurses and physicians. And since the pandemic, but certainly at the height of it, we're going to do hot spotting. So they would go to various inpatient units, outpatient units, and just talk to the staff, get a temperature on where the stressors were, to things like patient abuse or I'm anxious about my family getting COVID and whatnot, and then would bring those up at the highest leadership levels to really be more focused on initiatives that could address those issues. So it was a way to give voice to things that were percolating at the level of clinics or inpatient, and then to try to come up with solutions fairly rapidly. But it's a really very successful endeavor.
That sounds amazing.
Thanks, Kim.
reminds me, we did have a program where we had just a psych resident who came to our floors and spent time on our floors and just de-escalated patients and talked with our house staff and just helped them cope with the stress. And it was simple, which didn't need a lot of money. They didn't have access to their patient panels because the clinics were closed down. So they came and helped the general medicine floors quite a bit. It was really neat.
Great. Well, thanks again,
Thank
everybody.
you.
Appreciate it. And thanks again to Liz and Nicole for a great presentation. Thanks, everyone.
Thanks so much. Bye.
Thank you.